So this is the outline of my talk today. As we know that Barrett esophagus is a metaplastic change replacing normal squamous epithelium with intestinal type goblet cells. It occurs in 1 and 2% of general population, up to 15% in chronic GERD. So why you think it's important to treat Barrett esophagus? Barrett esophagus is associated with high risk of adenocarcinoma and rising incidence globally, and especially we are talking about GERD patient from 10 to 15%. Risk stratification critical to prevent progression. This slide emphasizes on the pathology pathway progression of Barrett esophagus. We started by non-dysplastic Barrett esophagus, and most of the patient may remain stable at this stage while continue. However, some patient who will have exposed to injury of the reflux and molecular changes may change to low-grade dysplasia. And low-grade dysplasia is considered as the first histological sign for neoplastic changes, and if not treated, can develop to high-grade dysplasia and ended by esophageal adenocarcinoma. So the risk factor associated with Barrett esophagus, usually chronic reflux, obesity, male sex, family history, and PPI, reduce inflammation, but not metaplasia. So some doctors, they are advertising that PPI with patient with Barrett esophagus may improve their metaplasia, and this is not the right sentence. Usually it's reduce the anti-acid, but it will not having any pre-rule in the metaplasia of Barrett esophagus. How we diagnose Barrett esophagus? Endoscopically, of course, with biopsy. Endoscopic finding, salmon-colored mucosa extend above the gastroduodenal anastomosis, and we can see here it's around the 3 o'clock. Histological confirmation require intestinal type goblet cells. The Bragg C and M criteria are used to measure circumferential and maximum M extent for metaplasia. So we can see here. This is the Bragg C and M criteria, and we can see from the gastroduodenal anastomosis extent circumferential, we can measure 2 centimeter as example, and from the gastroduodenal fold up to the upper part, this is longitudinal, we call it as a M. We measured here as a 5, M5, and usually some cases challenging, especially if we are talking about patient with hiatus hernia. So in patient with hiatus hernia, we have to do G maneuver to screen at least the lower part well and to rule out metaplasia. So the GI community divided into either you are with favor of surveillance or favor of endoscopic therapy. So the people whose or doctors favor of surveillance, they are talking about cost, because usually ablation there's associated with high cost, and the risk of ablation usually associated with stricture, especially we are talking about ablation. And what about change of interventional later? But the doctors whose favor of endoscopic therapy, we are talking about level of evidence which available now, and peace of mind for the doctor and for the patient as well. The evidence is quite mature in the real world, and from a randomized control trial, it started as a foundation of case series and observation, then cohort study up to randomized control trial, and then it's there in the guidelines, which synthesize all of these evidence. So this is, we can say this study as a game changer study for treating Barrett esophagus. In this study, it's randomized controlled trial where they enrolled more than 136 patients with Barrett esophagus and confirmed with low-grade dysplasia. Ablation was done in one arm, and the other arm was exposed to surveillance only. They found that there is a dramatic improvement in the progression of the neoplasm follow-up after 3 years in patient with ablation arm. Another study was also randomized controlled trial for more than 127 patients. With these patients were with low-grade dysplasia and high-grade dysplasia, and they found that after in the arm of the ablation, there is a dramatic improvement up to 90% in the dysplasia eradication compared to 23 with patients or who under in the surveillance arm. While the other patient, the progression of cancer was found 3% compared to 19 in patients who were under surveillance. So after that, landmark aim and serve trial. The question is ablation durable and safe in long term? This is one of the biggest study where in these meta-analysis, they enrolled more than 3,000 patients, and they evaluate the complete eradication for dysplasia, the complete eradication for intestinal metaplasia, and the recurrence of the cancer. And they found that the complete eradication for this study, the dysplasia was 91%, and complete eradication for intestinal metaplasia 78%. Recurrence was about 13. The side effect is accounted around 5%. So from this study, we conclude that radiofrequent ablation is highly effective, safe, and durable with very low recurrence and complication rate. This is the summary of all trials where they evaluate the efficacy for ablation and compare ablation with the patient who under surveillance. And also they highlight the durability of ablation for patients with low-grade dysplasia. Then the international societies came there and synthesized all the evidence. The ACG announced by 2024 confirmed that ablation is performed and recommended in patients with low-grade dysplasia, while the patient with with non-dysplastic Barrett esophagus surveillance only, and they require that two pathologists to review the histopathology and give confirmation for low-grade dysplasia. And the consensus from ESGE also, they strongly recommend ablation, and the surveillance was for non-dysplastic Barrett esophagus. The pathology was mandatory. BSH announced their recommendation 2024, where they go with the same rhythm of the other societies. So the guidelines review: ACG, ablation for confirmed LGD, surveillance for non-dysplastic Barrett esophagus. ESG 2023, same emphasize on the expert pathology review. PSG 2024 align with the both societies' recommendation. But what the different is in the surveillance interval different slightly. ESG strict on pathology confirmation. What about non-dysplastic Barrett esophagus? Why we are not doing that? Because the risk of the annual cancer risk 1 to 3 per year ablation is not justified. Non-dysplastic Barrett esophagus surveillance, it's if less than 3 centimeter, Q 5 years, from 3 to 10 centimeter, Q 3 years, more than 10 centimeter, expert centers. But why it's not, we are not ablating NBD, so we make sure that the patient will not progress to high low-grade dysplasia and high-grade dysplasia, because we know that the low cancer progression risk, cost effectiveness, no survival benefit proven, guidelines consensus agree on observe and surveil, risk of over-treatment and complication. So low-grade dysplasia, confirmation is key. Up to 75% community with low-grade dysplasia downgraded after expert review. Confirmed resistant low-grade dysplasia candidate for ablation. Downgraded low-grade dysplasia follow in non-dysplastic Barrett esophagus protocol. So treat only confirmed low-grade dysplasia. Ablation modalities, what we have now, we have radio frequent ablation. Usually we are using hot energy, cryoablation. We are using cold energy, and the gold standard is radio frequent ablation, although it's associated with the complication like structure 5 to 10% and bleeding rare. Excuse me? Network. Next, please. Okay. Post-ablation surveillance mandatory even after eradication. ESG 2023 protocol 1 year, 3 years, and 5 years for quadrant biopsies every 2 centimeter. Next. Next, please. Excuse me. Yes. Complication and management, structure, endoscopic dilatation, reduce energy density next session, bleeding usually mild, managed conservatively, and the recurrence treatment with repeat radiofrequent ablation or cardio, as we said, but radiofrequent is the gold standard. Reflux, optimize PPI, consider anti-reflux procedure in selected cases. Next, please. Next. Cost effectiveness of Barrett esophagus also. Radiofrequent cost effectiveness for confirmed low-grade dysplasia when life expandatory more than 5 years. Surveillance reasonable for non-dysplastic Barrett esophagus or high-risk surgical candidate. You can see here. Next, please. Future directions, we have AI-based diagnosis and risk predictions, biomarker, and robotic optimal image. Next. So, to summarize that, non-dysplastic Barrett esophagus surveillance, confirm low-grade dysplasia, ablation preferred, expert pathology review mandatory, post-eradication surveillance required, shared decision-making essential. Next. Ablate the confirm, surveil the rest. Thank you.
Thank you very much, Dr. Maryam, for this informative talk. So we'll have the question session now. So we'll open the floor for questions. Dr. yes. Do we have a microphone? Questions now, yeah.
Dr. Hamad, it's always the first one to ask.
But we'll try to keep it to less than 5 minutes, ideally 3 minutes.
Thank you, Maryam, for this nice talk and thorough review of the Barrett esophagus. My concern is about the surveillance. As you might be aware, there was a large study published early this year. It's BOSS study, and it was done in 8 or 10 centers in the UK over 10 years. And they found that surveillance in need is as equivalent to endoscopy at need is as equivalent as surveillance for endoscopy. So surveillance has no real point in reducing risk of cancers in Barrett esophagus. What's your take on that?
I think it's going with the same rhythm of PSG. But the problem, Doctor, what the challenge we face, our pathologist. So we are relying in our diagnosis mainly in our pathologist. So you have to make sure that your pathologist is good to detect that. And as I told you, 75% of patients who documented as low-grade dysplasia after reviewed by good pathologists, that percentage drop.
Thank you.
Dr. Hamad.
Maryam, welcome to Jeddah. Jeddah Ghair. Welcome. My question to you, we always see esophagitis. Do you give full PPI, let's say for 6 months, and then you take the biopsy? Because the problem in a government hospital is a general pathologist. which the east make it west. So the expert review, the gastropathologists who is interested in Barrett are very little. So my question, do you give PPI, let's say grade C, grade D esophagitis before you take biopsy for a period of time?
Yes, yes, I do. And especially the patient I'm giving who's candidate for fundoplication. So this kind of patient, you know, that fundoplication is contraindication to do it for grade D patient. So these patients, I prefer to give them double dose. But here I want to highlight one important. If your patient have definite diagnosis that he has low grade dysplasia, if you want to treat his reflux, go for traditional and the classic Nissen correction fundoplication and not endoscopic, because sometimes it may obstacle or challenge your vision while you are surveillance this patient.
Excellent.
I think we have to move on. Sorry for this. So we have to move on to the next session. Thank you very much, Dr. Maryam.
Thank you.